So good evening, everyone. This is official start time. Go ahead and place your name and campus in the chat. Also, check your screen name, ensure that it matches however it appears on the roster. As always, these sessions are recorded and they are viewed by the attendance administrators. If
Hello,
you
I have a question.
mm-hmm.
When you turned off homework grades, my grade went down. It's not the same, it's not showing the same as like it was before you cut the homework grades on.
You have unit exam two in there. Unit exam two wasn't there before.
It's still lower
Okay.
than
So you
that.
can just go to your rubric, your syllabus, and then calculate because your everything is weighted. So everything doesn't weigh the same. So you can do the calculations with your KGA and just check it like that. But it is just your KGA grades. And it
I was
does
just
change.
wondering on that as well because on mine, it says like my unit exams, and it's
Mhm.
not the same grade as what is put into the grade book at the moment.
Okay. Thank you for bringing that to my attention. All right. So again, welcome everyone. Make sure you place your name and campus in the chat and check your screen name. I've got that down to go back and check it. As always, these sessions are recorded and they're viewed by the attendance administrators. Is the expectation is that you're on camera. In the event that you cannot, for if it's an issue or something going on, just let us know. Just go ahead and log out. But the expectation is that you're on camera, and if you're not, you can't be. Like if you're going to the restroom or something like that, just put a message in chat to myself. Don't send it out to everyone. But if something's going on where you can't participate, you have to log off and then just send a message in the via email. All right, so let's go ahead and look at where we're at and where we're going. So we're almost there, almost there. Okay, pull up our modules. All right, we're in week 8. Let me share my screen here so we can see where we're going. Okay, so we're in week 8, almost there. So we just remember for unit exam 3, you only have 2 weeks of content. You have week 7 content, which mostly is about how do people pay for the healthcare that they're receiving. Remember, we're gonna actually toggle back, but just in a huge overview, how do people pay for their healthcare? We talked about all these different systems, PPOs, HMOs, Medicare, Medicaid, CHIP, all of those things. As I'm calling out those concepts, things should be popping up in your mind as in reference to what do each one of them refer to. So if any of those concepts you're still kind of fuzzy on or not sure what they are, put them at the top of your list. First, that's where you want to start at. But week 7 was mostly how we were paying. How do a person pays for the services that they receive, whether or not it is a program that's already out there that's funded by the state. If it's a program that's funded by the state and the federal government, some things should be popping up. Hopefully, some things are coming to mind. Whether or not it is a person that has too much income to qualify for one program, but then their income may not be enough to pay for private insurance. What insurance is out there that will cover the children up to the age of 19? Hopefully, things are popping up. Let me just stop sharing. Are some terms coming to mind as I'm giving out these little hints? Are you all understand what the children? What covers the children? Let me just stop. What covers the children?
Chip.
Yep.
Chip. Okay. So what comes to your mind when we say Medicare?
Elderly.
65 and older, federally funded
Yep. What about
and not income
Medicaid?
based.
Okay, go ahead.
Not
Someone,
income based, sorry.
it is not income based. Okay. What about Medicaid?
Income.
It is income based. So it's low income or limited income. It's whatever that amount, that dollar amount is that they have put in place to say, hey, you qualify for this. And remember, all of these are ways that a person pays for the health care that they're receiving. It's not really free because the money is coming from somewhere, but it's just how that their healthcare services are paid for. So a child that's subscribing to CHIP, okay, the family's income is too high for Medicaid. No matter if it's 50 cents over, if it's $500 over, it is too high for Medicaid. So does that mean that that child should not be getting preventative services, well child checks? Does that mean that they don't qualify to receive those services?
No, they still qualify.
Exactly. They still qualify. It's just CHIP is paying for those services. Matter of fact, we want them to get those preventative services and also those children checks as they are, scheduled and as they are permitted. Okay. Now, who pays for Medicaid on a higher level? Who pays for it?
That's federal and state.
Yeah. Remember, we did say that some states may not have expanded Medicaid, but nevertheless, it is funded by both of those, the federal and the state government. Okay, so if a person, and we talk about custodial care, and so for the most part, that is like ADLs, baths, turn and reposition. We're not talking about skilled care. Remember what skilled care is. So custodial and skilled are not the same thing. Skilled is like your dressing changes, person's beginning receiving therapy and so forth and so forth. So let me see the mean here. Okay. So does Medicare cover the custodial care? If a person was to go into, like they were at home and they just needed custodial care, or does Medicare cover skilled care?
Yes.
Yes, skilled care, or yes, custodial care?
Skill care.
Skilled care. So watch those terms. No, you know what you know about Medicare. Even though the person is how they would pay for their services, but it's the word for Medicare is skilled care. Okay. So what about, I didn't mention, let's see, value-based care. Give me an example or tell me what that is. What do insurance companies do with this value-based care? Value-based purchasing or value-based care. What is that all about? This is a safe space, so if you get it incorrect, we'll correct you, but I know you're going to get it correct. Value-based care. Think about it. They put value in what we do. The care that we give, that particular resource says, hey, or they say, hey, I'm trying not to, I want to hear from you because we've been going over this. Value-based care. You can give me an example or scenario. Value-based purchasing.
Is it doctors that are rewarded for the outcomes of the patient?
So to speak, it is. So they more so look at it on the opposite. They don't reward you if the care isn't, up to the standard. So give me an example of that. So they do reward you on the care that's given, but they don't pay you in the event that the care is below standard. So that's
Is
correct.
it like if you get a bed sore at the hospital, the insurance usually sometimes won't cover a portion of the care due to the not turning the patient?
Exactly. Because if they came in, they were admitted to the hospital and a wound was not related to why they came in. The person came in and, they had we'll say a hernia repair, hip replacement, the expectation is that this person gets well and go home. The expectation is not that this person gets an ulcer, a wound. In the event that that person does, they're going to track it back. More than likely, if there are not any disease processes, any labs, radiology, anything that supports or indicates why this person has this bed sore or ulcer, then that means that the care was not valued. There was a less value in the care that was provided, meaning that staff didn't do what they were supposed to do. This person wasn't turned to reposition and assisted like they were supposed to. So they put a value into the care that the person receives. And they say, hey, this is low value because the standard was not met. If a person ends up with a disease process or something wrong with them that's not matching why they are there. So give me another example. So we said an ulcer. What's another example that we got?
Like if a patient comes in for like a surgery and they end up with like pneumonia.
Okay. So what does that mean?
That means that either they weren't educated or they weren't treated or moved around properly to prevent.
Exactly. They were not educated on the symptoms spirometers, to cough, deep breathe, and or if they relied on us to, one person or two persons assisting. That means we more than likely did not go in and reposition them at a minimum of every 2 hours. People can be repositioned more than that, depending on what's going on with them. And for sure, if a person needs 1-2 persons assistance, and they just had surgery, at least for that first 4 hours, they'll be more than likely repositioned more than every 2 hours. Someone else, what's another example that that when we're talking about value-based purchasing, part of that Medicare, they say, hey, the standard was met or the standard was not met. And if that value wasn't there, that key quality standard or measure was not met, then they'll say, hey, we're not more likely going to pay for these. You can take care of this person. I want you to offer these services to them because we need to take care of that's happened. But more than likely, they're not going to pay because if the documentation doesn't support why that person ends up with pneumonia, why that person had an ulcer. Give me another example. That's real. Is more common than it should be.
It's like if a patient falls
and falls. That's a good one. What else? What's another one? UTI. Falls, UTIs, and ulcers. That usually those are like the top 3. So yes, they look and say, well, hey, this person came in for this. This is unrelated. But then they will, one of the job titles they call them different things in different settings that you can do is you go back through that chart and you backtrack. You look at the documentation from the UAP, from the PCT, from the RN, the LPN. They look at the care plans and they say, well, hey, did the people do what was outlined in this person's chart, this care plan, so that this person would not have? Then they look at, they actually go back and see who, with the urinary tract infection, they look and see who put the Foley catheter in, what was documented, what was the facility's policies and procedure regarding that first urine catch. They look at all of that. If things are not lining up, they can decide, hey, we're not paying for these services because the value wasn't there. So that's that value purchase. But falls, UTIs, and ulcers are top 3. Then there are others, but those are the ones that are more common, unfortunately more common. And then the pneumonia, especially for those that are not able to turn and reposition themselves. Okay. So
excuse me. So they expect you to care for the patient. Like they're not telling you like, hey, kick them out. They want you to give the care for the patient, but they just won't cover for the cost.
Yeah, exactly. They won't do that reimbursement. Because so again, when that person's admitted, that's why it's so good to do that in-depth head-to-toe assessment. Whatever data they give you, that subjective data, you want to capture it, because sometimes when people come to the hospital, they don't really remember everything that's going on or has been going on that's led up to why they're there. But then if you ask these focused questions, and then make sure you're documenting whatever it is that they're saying, if something else comes up while they're there, we can go back to the documentation and say, hey, Oh, they did mention this to nurse A when they were admitted, or on day 2, they mentioned this to the nurse. But then no, they don't want you to kick them out. They're not gonna tell you to kick them out. They're just not gonna reimburse. They're just not gonna reimburse for that. All right. So we said, okay, so you tell me this. Funded by the federal government.
Medicare.
Okay, now you all just told me these things now. Let's see, income based, specifically income based.
Medicaid.
Okay. So what if I say income based, you said Medicaid. What if I say low or limited income?
CHIP.
Well, what if I say low income? You're right, because that is CHIP. CHIP is limited, but low income.
Medicaid.
Medicaid. Limited is CHIP because you make too much, but you don't make enough. Got it. So low income is going to be your Medicaid. Got it. Let's see, 65 and older and is not income based.
Medicare.
Okay. And let's see, who pays for Medicare?
Federal.
Federal.
Federal government.
Okay. Part A.
And you pay it out of your check.
So it's federal government. Those
It's
funds come from the
federal.
federal government. Yeah, we have all these people listed on our check, on our stubs, and they go all these different places, but that money comes directly from the federal government. Okay, so Medicare Part A.
Hospital stays.
Okay, so N. What about Medicare Part B?
Is that medication?
Medicare.
Surgeries.
B as in boy. I'm sorry. It may have sounded like D. But say D is for Danny is drugs or medications or prescriptions. Remember, all those are the same thing. Prescriptions, drugs, medications. What about Medicare Part B, like Bobby?
Just doctor visits.
So outpatient things, outpatient. Okay. And then we said C was that extra coverage a person can actually subscribe to, and it does cover medications in addition to the Part D. But C, they have to subscribe to it on their own and pay for it on their own. And what was other about medications? We did D, A, N, B is outside. Okay. So limited income again. Who we said limited income? What type of insurance?
CHIP.
Okay. All right. So if you're not coming off mute, at least answer these questions to yourself or jot them, jot what you think the answer is, because it's gonna, and it helps you identify what you don't, you still need to review. All right. So we were on, so again, week 7 was
Question.
how do we go ahead.
What was Part C?
C is prescriptions drugs, but it's the part where the patient has to pay for it themselves. D, they automatically get, which also covers medications and prescriptions as well. But C is another part that's there that Medicare patients that's offered to people that's on Medicare, but they have to pay an additional fee for that.
So is that the one where they have like co-pays and stuff like that?
That's D, that they automatically.
Oh.
C is a whole different, yes, it's a whole nother, they have to subscribe to it. Like, for example, if they were paying, in the event that they were subscribing to a private health insurance, really C is kind of a private health insurance if you want to really look at it like that, but it's only available for those that are on Medicare though. So a person that's on Medicare and they have several probably chronic conditions and also medications that are kind of higher priced, because medicines are very expensive, but there are some disease processes and medications that only fits or works for a person that they're able to manage their care. And sometimes those are the higher price medications. They're the brand names. They cost more than the generic names. So if a person, that's what the Affordable Care Act opened up for. So if a person knows that they are going to require a certain medication, and this medication is expensive, despite that they also have this Medicare Part D, as in Danny, they have the option to also subscribe to Part C, because otherwise D is only going to cover so much of those meds. So the person looks at it and they make a decision and say, hey, well, if I subscribe to C, even though I have to pay that monthly subscription to have it, it's still cheaper than me paying out of pocket for the rest that Medicare Part D does not cover. Like I said, there's just some disease processes, and then also some medications that only work for, certain people. Some people need brand name medications. And, unfortunately, those brand names cost so much more than the generic name. And so, like I said, a person, what they'll look at and they'll decide, well, hey, I need this medication to manage my disease process because I found out this one works for me. But if I don't subscribe, pay this extra fee to have Part C, then that person will be out of pocket paying for that medicine.
So basically, it's like a backup. So like if let's say like my medication is way too expensive that my Part D don't cover, then I can have Part C kind of take over that part. But I would have to pay like a monthly subscription for it, apart from like whatever I pay on my Medicare.
Exactly. Just like that monthly subscription to Prime or Netflix or something, or Blue Cross Blue Shield. Yes.
Yep.
Something else came, but then remember that's Part C. The same thing is the same for Medigap. Medigap is a whole different thing. It covers the inpatient, outpatient. C just is that extra that a person can subscribe to for medications. Medigap is another one out there that people just, it depends on what people have going on. They may need all of these radiology tests. They may need numerous MRIs. They may need numerous CT scans, echoes, and so forth and so forth. And while they do have these coverage, there are, like a certain number of these exams that you can get, even like with the CHIP and even with the Medicaid and the well child visits, there's a certain number in a certain amount of time, and so, but they don't want to prevent people from taking care of themselves. So what they do is, someone's created these other resources so that people can subscribe to them, but that just means they have to pay out of pocket on their own. But people say, hey, it's, even though I have to pay that extra fee to subscribe, it's still cheaper than me not subscribing and having to pay the other part out of pocket. I know. Remember when at that first slide I asked you, I think at the beginning of week 6, creating this perfect healthcare system. There's so many moving parts, it's things you have to think about. And if a person, they have an allergy to the generic brand, and if they don't have an allergy, but they found out that the generic of that medication doesn't work and they need the brand name, there's so many moving parts that we have to think about. And so that's why they created all these different resources in hopes that people can, be able to manage their disease processes and live, to their optimal health level.
Yeah, like a loophole to kind of get the help that you need anyways.
Exactly. So private health insurance, while it's designed to make healthcare more affordable, what they saw about private healthcare, it kind of made healthcare costs go up. And so with that being said, they created all these other things, not things, but resources like Medigap, the Medicare Part C, and those things, even CHIP, to stand in, to take the, the front off of having to pay for healthcare services. Okay, so that's pretty much pretty much for how we pay for healthcare. We did talk about the Affordable Care Act though. And then, so what are some things that you remember about the Affordable Care Act? What do they do for employers? So the
Isn't that the one that they have, like if they have more than 50 employees, they have like they get that, and then that's like what pays for like it's like a cushion, like money that goes in like for events like that happen.
So that is where the employers offer um, the the insurance for the employers. Before the Affordable Care Act, employers really didn't offer. Some did, but a whole bunch of them did not offer the employee the opportunity to get insurance through their company, which would have been a cheaper price. That subscription that you pay every month, if you get it through your employer, and it versus you paying it, if you were to subscribe to that insurance company on your own, there's a whole different fee. So the Affordable Care Act did open up for the employers to be able to offer that. Now you didn't have to subscribe to it, but they at least offered it to them because it was a different price. It was a whole different price. But before then, you just bought it on your own. Unless you were employed by someone that really did just outright offer it. Then the Affordable Care Act, it did not penalize you for pre-existing conditions. Remember, it removed those lifetime limits. For example, if a person had hypertension and their hypertension care prior to the Affordable Care Act, we're just going to throw out some numbers. Hypertension care, if it totaled more than $500, then that was all the companies were going to reimburse for. Anything beyond that, the patient had to absorb the cost. And so that's why you hear prior to the Affordable Care Act, people having these huge hospital bills and medical bills, and people filing bankruptcy because those healthcare it costs a lot. For exams and procedures, medications to keep following up with your doctor, and so forth and so forth. And so it removed that lifetime limit coverage. It removed you were not penalized for having hypertension, for having pre-existing conditions. But nevertheless, all of these resources out there, you all, it's so that the patient can receive that best care, that best care. They want to eliminate waste. They wanted to control costs, which is the same thing as eliminating waste. They wanted to, what's another way I can say it? Unnecessary care. For example, if a patient was seen by their main healthcare provider, their primary, and they had ordered a CBC, and they found out that the red blood cell count was abnormally high or low, and they referred them to a hematologist or someone. And so once that patient was seen by the hematologist, they redrew the labs like pretty quickly, not within like 2 or 3 weeks to see had they improved, not after treatment was initiated and we drawn to see if the treatment had done any good or not, but like soon after. Nothing had changed in between. They had seen their primary healthcare provider and them seeing the specialist. Nothing had changed other than a date. No interventions had been implemented. The patient status hadn't changed. And so that's an example of unnecessary cost. And they consider it as being wasteful because, if nothing had changed other than a few days, what was the necessity to order those other labs? So that's where that managed care, it tried to eliminate, which all of these, but more so that managed care, the MCOs, they tried to reduce that excessive and unnecessary care, And so once that second doctor submitted charges for having to redraw that lab, a nurse, most of the time it's nurses that review this and they look at, well, hey, this person just had these same labs drawn 2 days prior or a week prior. So what they'll do is they go through the records and see if there's been any interventions, medications, lifestyle modifications that were supposed to have been implemented. They'll look at all of that. And if they don't see any documentation that says, even if the person was non-compliant, even if it was ordered, but the client didn't follow through, they don't see where it was ordered at, then more than likely they're not going to reimburse. The other thing about MCOs too, that managed care, controlling the cost, they submit that lump sum too, for whatever services. So if you're saying the person's being admitted to the hospital and they're coming in for a right hip replacement, and those are the charges that's submitted. And that's what the MCOs do. They say, hey, we send you this lump sum, $500, take care of the hip. All this other stuff, that comes with, for example, if a fall comes, if the person ends up with a UTI, if they end up with an ulcer, it's like, no, hey, what, they look at that documentation and say, hey, this part is not expected. It is not reasonable to think a person will come into a facility that did not have an ulcer, that was not prone to falling, that did not have a urinary tract infection. It is not reasonable to think that someone will automatically have those things happen to them. And they say, hey, we gave you that lump sum, you know, that's it. Now, the facilities, what they can do is, people that work in the finance department, where they resubmit those charges, they also have to resubmit documentation. So it's really important that we're documenting everything. Even if you were with the urinary tract infection, even if during the sterile procedure, maybe the patient, I don't know, put their hand on the Foley catheter. You want to just make sure you give a good picture of what happened, just in case. Even though you stopped and restarted because sterility was broken, you still want to capture what happened, is why you stopped and restarted. If a patient is, I can think of maybe like those lock units, like the dementia units. If someone's constantly hitting on the door, knocking, even they're just knocking continuously, that's not normal. Over time, that's going to injure the skin, the blood vessels. That person might end up with bruises later on. It's so important to document what that person has been doing, because you just never know. And then later, the next day, when the person has more than likely bruises on their, knuckles or their hand or their fingers, we were like, okay, what we do remember is documented that this person was continuously just knocking on the door, even though, we went and provided reality orientation, all of that. We tried to redirect them, but we still want to capture that they were continuously knocking, because that's not normal. And more than likely, it's going to injure that person. Even if the person with the ulcers, even if the person, we turned to reposition them and family members came in and turned them because the patient said they wanted to be on the other side, you want to capture all of that, because what it's going to look like is that we didn't turn and reposition them. If you go in the room and we turn and reposition them and we go back in 30 minutes for something, like, wait a minute, I just turned and repositioned, you were turned, more toward the left. What happened? You want to capture all of that, because in the event that person ends up with a ulcer, it's gonna look like we didn't do what we were supposed to do. So you want to capture all of that, because of that value based. The MCOs, they're gonna give you that lump sum and say, hey, take care of them. So PPOs and HMOs, which one allows for the patient to be seen if they want to go to an out of network provider? Which one, PPO or HMO?
Is it PPO?
Okay. PPOs allows the patient to see out of network providers. They allow them that, but doesn't mean that the cost is going to be low though, but they allow that. So yes. So on the opposite, the HMOs, you stay in network. You stay in network. And then PPOs. So the HMOs typically kind of sort of have a limited network of providers. You can go and see someone out of network if you have an HMO, but you have to follow that referral process. You got to be referred, then that referral has to be approved. But then the PPO, it's usually a huge network, a whole bunch of doctors are available. And, the patients just outright just decide, hey, I just want to go see this person, and if they subscribe to that PPO service, they don't require that referral. So again, all of this is how we're paying and people are managing their healthcare. All right, so let's move on to I think we got everything for paying for healthcare. I think we talked about everything. Again, those concepts that you are, unsure of paying. We talked about Medicare, Medicaid, CHIP, MCOs, Affordable Care Act, value-based, HMOs, PPOs. Jot them down, those that you don't, and try to put a scenario with it, just like how you all gave me different scenarios with, the value-based, the falls, the ulcers, the UTIs. And even with the Medicare, create a scenario of a person coming into the doctor's office and they're saying they need assistance with filling out for insurance and they are 65 and older. Which paper are you going to give them, the Medicare paper or the Medicaid paper? Just trying to create a scenario so that therefore, no matter how you see that concept asked about, if it falls in a scenario, if they ask you a direct definition, you still were able to answer that. Okay, so that's week 7. Okay, now week 8, which is where we're at, we're looking at theories. We're looking at evidence-based practice and the evidence. We do have some points to ponder. Let's see here. And there's a connectivity issue in my area too, you all. If I fall off the internet, if I lose connectivity, just stay there. I'll try to log back in. And if it's happening with you too, just keep trying to log back in. Because we've had a bunch of like little pop-up thunderstorms. So, but hopefully we'll make it out without, but you just never know. All right, so let's look at these theories here. Get them pulled up for us. We did talk about the was it PDSA? So let's pause. Give you 2 minutes. Need you to put in the chat PDSA. I'm gonna put my little timer on here. 2 minutes should be enough. Timer. And give your definition of each and send it out so everyone can see it, because therefore, the more we read it, even though you are going to pretty much say the same thing, you're going to say it a little bit different, and therefore it's going to stick with us. We're going to have a good understanding. So PDSA. All right, timer, 2 minutes. Go on mute here in the chat. Just share it out with everyone. Okay, we're still waiting on responses, you all. Another minute.
I'm sorry, what was the question? Because it kind of lagged for a second. You was frozen. I heard
P-
nothing that you said.
PDSA.
Okay.
Talking about PDSA. What does that PDSA stand for? What happens? What's your understanding of PDSA? All right, let's look at our little PowerPoint here. Let's see what we got. PDSA. Let's look at this slide. See, does it match what you were thinking and what you placed in the chat? So you take a look at it and see how did you do. Okay, so plan, define the aim in the question and predictions. Plan your data, collection to answer the questions. And then do is like implementing. We try to change idea and then collect data. We always collecting data. Remember, we kind of said this kind of matches like our care plans. We go in and do our head to toe assessment. We gather our subjective and objective data. Then we come up with these goals and interventions and then we implement them. So it's kind of sort of like that. And then the S part, we analyze the data and compare to the predictions. And then we plan the next cycle. We can implement the change if we think that this change, the goal was met, if it was effective. Now, what if we complete the plan part and we get to this part right here and we say, oh, we want to, after we looking at the data, we want to go back to the plan part. Is that okay when you're doing PDSA, or you must go through all of the different levels before you can go back? Or can you go back and forth?
No, you can go back and forth because that's the whole part of it. It's like you get to test everything out before you execute the whole thing or like actually show it off like, hey, this is everything that happened or this is how it's going to go.
Got it. I do agree. You can get to the study part and say, oh, I think we need to go back to the planning stages. Exactly. Yeah, so you can get to the next stage and because of new data, a new thought about whatever it is, oh, we need to go back because this really wasn't the issue. And so, yes, so you can go back and forth. You don't have to just completely follow um, it as it out. But those are the steps for it. But if you get to one area and then something else comes up, you identify a new issue concept or something that you haven't looked at in that way or thought about it in that way, then yes, please go back and you can go back to the previous stage. We talked about steep. I'm going to pull it up. So let's do steep the same way. What is STEE, three E's, P stand for? What do you recall? I'm going to share the slide. We talked about that last week. Steep. It was those six guiding aims. Um, STEEE, P, I'm sorry. P. So steep. What do you remember about steep? What were those guiding aims about? You could just give us a one-liner. If you want to define each what the acronym stands for, you can. We'll give you 2 minutes. So you are writing in the chat. When we're talking about those six guiding aims, the acronym is STEEP, STEEP. What do you remember about that in whole, or if you want to list what each letter represents? Give you that 2 minutes. Then we'll look at it here. All right, let's see what you put in the chat about Steve. Let's see here. All right, so make sure that you're reading what your classmates are putting in the chat. Of course, they're pretty much saying the same thing, but just the more we see it, automatically it makes us have that stronger understanding. And also, if the test question asks you in the negative to respond in the negative, meaning what steep is not, then you will know what steep is because you have your own understanding. You looked at others, paraphrase it. And so either way you see that test question, you're able to identify because some of those questions I know are in the negative. It asks you to identify the things that a concept is not. Okay. All right. So I found the slide that we looked at last week on steep. So let's see. How did you fare? Let's see from current slide. Okay, see what you put in the chat and see, does it match? Safe, were you talking about avoiding injuries to the client from the care that is intended to help them? We talked about those, person getting a UTI, person getting a wound. We're administering medications and we didn't follow the medication administration's rights. We didn't identify the person correctly. So we're administering medicines that we're not supposed to. So are we avoiding injuries to patients from the care that is intended to help them? safe, being safe. Timely, reducing wait times, sometimes harmful delays for both those who receive and those who give the care. Remember, the example that I gave was, I think we talked about chest pain. You know, a person shouldn't be sitting in the waiting room for hours and hours if they're coming in with chest pain. Certain things, we want gotta move, but nevertheless, all together, facilities, especially urgent care and emergency rooms, they created different options so that it does decrease wait times. I think the example that one of you all gave last week was where if the person comes in, they're focused on that presenting complaint or presenting issue, and all those other questions they'll get answers to them, but they're going ahead and addressing the problem the reason why the person presented. Another thing that comes to mind, I know in a lot of emergency rooms they have, and they call them different things, the fast track lane, where if a person's coming in with something that they're more than likely with, if they're presenting with, they will not be admitted. They go ahead and place those patients on a different wing or track of the ER. And so they will still receive the best care. But like sometimes, the person might just need, pain medication and their condition doesn't warrant them having to be admitted. Now, it does not mean a person will get to the fast track area and that condition changes and they end up, admitted. That doesn't mean that they will not be admitted if they really are supposed to. But the whole point was that to reduce wait times. So making sure that we're timely. So what about effective? Did you have effective? Provide services based on scientific knowledge. Have the policies and procedures been revised? Do they match our Nurse State Practice Act? Have they moved within the last 5 years of information that they're using? I think the example that I gave was where we used to check the balloons for the Foley catheters. We used to inflate them just to make sure the balloons were staying inflated, but now we don't even do that. Efficient. Avoid waste of equipment, supplies, ideas, and energy. Equitable. Provide care that does not vary in quality because a person's characteristics such as gender, ethnicity, or socioeconomic status. And then patient-centered. What are the client's preferences? What do they know and understand about their disease process? What are their goals? What do they value? All right, so how did you do with that? Did you get STEEP? So we did STEEP, we did PDSA, we said value purchasing. And as I'm going back and repeating myself still, as I'm saying these concepts, things should be coming to mind. I'm just not repeating just to repeat. I want you hear it, you see it, automatically got it. Automatically got some things should be coming together. All right, let's go ahead and pull up our. Oh, did I see another slide I wanted to go over? Let's see. I know we see it. I know PDSA. Before we move on in, let's look back at this. We talked about managed care, but let's just look at it again. Managed care, we talked about PPOs, MCOs. Let's look at these 3 slides, and then when we come back from break, we'll go on into our new content. Okay, let's look at these. Let me share my screen. Okay, so we talked about the Healthcare Reform Affordable Care Act. Enhances the access and affordability of healthcare, particularly to all citizens in financial need in the United States. Decrease the number of uninsured because it made healthcare more affordable. People were able to go in and pick and select the plans that works best for them. It eliminated lifetime coverage limits, reduced prescription drug costs for Medicare beneficiaries. Because remember, they're 65 and older. For the most part, these people are retired, so they're more than likely on fixed income. So we're looking for ways to help them offset those costs that they'll have, because they can't just go pick. More than likely, they're retired and they're not going to pick up another shift to cover, an unexpected expense. So they created all these other resources to help them with those costs. Allowed states to determine whether to expand eligibility. Pre-existing conditions are covered. Imposes penalties for larger employers that do not provide that insurance. Remember, someone said, 50 or more, they were not, employees were not giving the employees opportunity to subscribe to the health insurance that they could provide at a lesser rate through them. Okay. So MCOs, we got the PPOs, the HMOs. Healthcare providers and insurance companies share the financial responsibility for improving quality of healthcare. Patients pay that monthly premium, that subscription premium for healthcare insurance, and are able to choose different plans. So they're able to decide, well, hey, I want to stick with the PPOs. Those are usually the lesser costly plans that don't usually cost that much. Because with this one, you can still see someone, but remember, you know, you have to get that referral. Patient receive health care from a list of providers who participate in both. And, they look around. If they've already had a doctor, then they try to see which way, especially if that doctor has been assisting them to manage their care. They just try to pretty much see which category they fall in. And that's the way that they go. But I think I told you our back end was it October, November. A lot of patients were saying that their patients were in network and something happened and they were no longer in work. Their doctors were no longer in network. So they had to find new doctors and or decide to pay that out of cost pay to continue to see that doctor. Price for healthcare goods and services are set beforehand by the insurance company with this. Remember this lump sum. Providers may suffer losses if their costs for providing care exceed the payment received. So, providers may submit all of these charges, but because MCO says, hey, we're going to submit you this price, then, you can provide that care. We want you to provide the best care, but this is all we're going to reimburse you. Okay, ACOs, organizations of healthcare providers that are accountable for the everything. Every time you look at one, it's the quality cost. They want that best care to be provided for the patient. Must have defined processes for promoting evidence-based medicine and reporting accountable. They have that reporting piece that you have to report. And we're going to talk about those regulatory agencies here when we come back from break. So QSIN, we'll remember about quality and safety education for nurses. The overall goal was to prepare nursing students with the knowledge, skills, and attitudes necessary to continuously improve the quality and safety of the healthcare systems. Okay, and I think that was it before we went. We talked about STEEP already. Yep, that was it. All right, so let me look at my time here. Are there any questions about those concepts that we've been covering now for those concepts? Any questions about that? Okay, when we come back, we're gonna look at the healthcare policies and just move forward with it. I think we've went back and gotten everything. If not, I'll bring it up and we'll go over it here. So let's return at 6:36. Remember this video still runs. Turn your cameras off and make sure you're on mute. See you at 6:30. All righty, let's get started. So when we talk about, let me share my slides here, but when we talk about that continuous, that being a competent nurse, that continuous competence, what are we referring to as a healthcare provider, as a nurse? That continuous competence. What should we be doing? What are we going to have to do to keep our license current?
Continuous education.
Exactly. It's continuous education, whether or not it is, on in that facility itself, and or whether or not it is, in order to maintain our license. So sometimes there's unit-based education that you'll get depending on what unit you're on. For example, if you get new equipment in the event that, we talked about quality insurance. If they have um, identified a process that's in place that we might need to be retaught on because they're seeing the outcomes, for example, a high number of urinary tract infections, and things like that, they will have unit-based training. But nevertheless, you're continually making sure that you're competent and have a good understanding of foundation about whatever the concept is. In order to maintain your license, they require you to have so many hours. Now you're able to go and pick what those hours are, just as long as they're an approved provider by the state that you're renewing those licenses. But yeah, so unit based, you may have where you decide on your own the and even more broader within that facility, especially like long-term care facilities, they have some trainings that you must complete every year, like on abuse is one that comes to mind. But then, like I say, unit-based training where they will do it specifically to that unit, but nevertheless, you're getting that latest information on whatever the concept is, whether it's not this new information about a procedure that we're doing on that unit, new equipment, or a process that we need to, if they have to revise a policy, if they deem it that we need to be retaught a skill, then you'll get that information. So the National League of Nursing, it's you more than likely will subscribe and be a member of this as well. But the whole thing is it sets these standards. And so from these standards comes our education. It tells us how much seat time we should have. For example, if you're taking this class is a lot longer than, our geriatrics class or another class that you might have taken. You might have more clinical hours to complete for a course versus another one. But the whole idea is for us to be excellent in what we do. So the National League of Nursing oversees that. That's that huge body or entity that kind of governs and sets those standards. So the NON, this goal applies to all levels of nursing. The organization developed models and competencies to guide the nursing education. They said which skills we should be completing in the skills labs. They even kind of oversee what we set up in the simulation lab. The National League of Nursing's focus is on meeting the needs of nurse educators and advancing national health. So we're providing the best care for all of our patients. So getting ready to get into these models and theories. So, and all of this stuff comes from these models and theories. We have these official government agencies. They're focusing on disease prevention and wellness, and then making sure that people can manage, no matter if they're in the community, no matter if they're home, if they're in a facility, no matter where they're at. We're going to talk, you all remember, we kind of briefed on the other week, we talked about JCAHO, these governing bodies that comes in and look at the documentation, look at our processes. Okay, so rationale for theories. Numerous nursing theories have been developed for nursing. There are so many of them out there. Some of them are the basis of curriculum development. Which information should we be going over while we're laying the foundation, while we're getting that foundation to go out and practice being nurses? Three concepts are important when we're looking at this curriculum development: the person, the health, and then the environment. So the person that's receiving the care, the goal of nursing, which is to prevent. We can prevent a disease process, and we can prevent an injury, we can prevent that ulcer, that fall, whatever that goal is. And then the environment, the setting where the nursing care will actually take place, where, it may change just slightly if we're in the home versus if we're at the urgent care versus if we were in the long-term care. Think about all the different settings. If we were on same day surgery versus the operating room and stuff like that. So the environment where the patient is receiving this care. So we got Florence Nightingale, the first nursing theorist. She was the first to emphasize environment, ventilation, warmth, noise, light, and being clean. Wow. Often spoke of as the first nursing theorist, Nightingale felt strongly that environmental issues, our environment, where we're at, where we're receiving this care, influence how well we did with recovery. It influenced whether or not we were sick or not. Just think about if you have a healthcare provider that goes from patient to patient to patient and they don't wash their hands, but the first person they went to may have had some type of contagious, infectious disease process, and that healthcare provider placed their hands on whatever it was. It goes from person to person to person. And so the cleanliness part, whoever would have thought, okay, we need to be washing our hands. And then they brought it in, that friction needs to be a certain time frame. But nevertheless, here we are. We have Abraham Maslow's human needs theory. Am I worried about self-actualization if I don't have anything to eat, if I don't have anywhere to stay, if I can't breathe? So you remember Maslow says, hey, these basic needs, and you can go up and down the triangle, but these basic needs must be met. And so the theory states that certain internal and outside physical and psychological needs are common to all people. Food, water, shelter, those are common. Unmet needs create tension, in which motivates the person to react to meet the need. A storm just came. A person's without shelter. Their home, the roof is up or their home has been destroyed. Now that's an unmet need. That shelter is not met. So that creates this person to seek out shelter, whether that is with a relative, a friend, family member in a shelter, or seeking hotel stay, whatever it is. But nevertheless, it's going to create tension. This person is going to try to seek out shelter. When needs are met, the person is no longer aware of the need, and the need now met no longer motivates that person. Once that shelter is person safely sheltered, then that's not an issue. They don't really think about it much. We have Orem, or Theo Orem, is a general theory that has 3 sub-theories. So I want to stop right here. Someone read self-care for us. Then I need another person to volunteer and read self-care deficit, and then one last person to read nursing system.
Self-care goal is to direct it towards the safer environment for health, for life, health, and well-being.
Self-care deficit, personal care does not meet therapeutic self-care demands.
Nursing system, nurses empower the client through their interpersonal relationship to help meet their self-care demands.
Okay, great. Thank you so much. And so this nursing system, we're there empowering that person to be transformational, transactional, so that change, if they can, at a minimum, at least motivate them. So that's why it's so early to establish those therapeutic relationships, even though, they may not, but we still want to establish those therapeutic relationships. We will not change rules. We're not going to break rules because of the patient's preference, but we do acknowledge their preference. Let me stop right here, you all. I did go back and check before I get to tell you all the quizzes were still on. The quizzes were not off. KGA is just your HESI and your exam. So I just want to tell you all that. The quizzes are not part of your KGA. That 0 that I put there didn't stay. So anyway, so it should go back to what your grade was before. All right. So Orem, three parts: self-care, self-care deficit, and then that nursing system. We're that bridge. We're empowering that patient to to help take care of, to identify, and hopefully be able to get them back to the optimal level so they can take care of themselves. But if not, to be acceptance of care that they will need from someone else. Because sometimes they can't get back to that optimal level, prior level to a stroke or prior level to whatever disease process. They may have had an accident, car accident or something. And, they're not able to get back to the optimal level. But part of it is empowering that client also to accept assistance from others. That's the problem sometimes. They want to be independent, and they're as independent as they can be, but that other piece are needing someone to assist them. So that's still helping them to be empowered to receive help, the help that they need is a part of it as well. Okay. So Linenger identify two kinds of care in every culture: generic, professional care. Okay. So generic meaning home remedies. If and sometimes healthcare providers will also, write those orders for whatever those home remedies are, as long as it's not going to cause that person any harm and us any harm from administering or assisting with them. Linenger proposed 3 modes to guide nursing decisions when providing care. So I need someone different to come off mute and read one of these. Linenger proposed 3 modes to guide nursing decisions when providing care. So someone read 1, 2, and 3.
Cultural care preservation or maintenance.
Next person.
Cultural care, accommodation, or negotiation.
Okay. One more.
Cultural care, repatterning, or restructuring.
Okay. And so in the event that a practice that this person has that is not conducive to their well-being, that's that repattern or restructuring, giving them an alternative, allowing them to make an informed decision. We're going to support them no matter what they decide, but we do know sometimes, some things that the patient, whether that is a home remedy or whatever it is that they're doing, is not conducive to their optimal level of health, whether or not it's smoking, whether or not it is adding extra salt, not adhering to the 1,800 calories that are supposed to be consumed if they're on a special diet. It could be an array of things, but this repattern or restructuring is helping that client to make an informed decision. And hopefully they'll change to what we found to be evidence-based to be better for them overall. It's still up to the client to decide. So we have Pablo, Hildegard Pablo, interpersonal relations theory. Okay, so there have 4 overlapping phases. So someone read orientation, re-identification, exploitation, and resolution. Tell us all about it. So come off mute, even if you read before. But if not, for sure, let us hear from you.
A basis for developing a therapeutic relationship with a client.
The relationship that is developed has certain parameters and is the major part of the treatment.
Orientation seeks assistance because of a felt need.
Identification understands the situation and responds.
Exploitation begins to depend on the nurse and uses the help offered.
Resolution dependent behavior must now be given up as a therapeutic relationship ends.
Okay, thank you all so much. So this part right here, the exploitation part, begins to depend on the nurse and uses the help offer. Sometimes this is a biggie for people, it's not that they don't want your help, but it's just like they've managed their lives all of this time. And here we are, they're admitted to the hospital for 2 days, and here we are telling them these things that they need to do differently. So that's a biggie where, that they seek out that assistance and then they understand, but then they begin to depend on the nurse and use the help that's being offered. Okay, we're going in reinforcing their education. They start asking us questions. Well, you said, something about, you know, uh, watching my calorie count, watching the number of starches. The person could be on dialysis, watching the number, my protein, making sure I have enough fluids. They're on a fluid restrict. So whatever it is, they start to ask you questions, and then they start to, rely on what you're saying, to reinforce whatever the information is they need. And then once they gain that understanding, they clip your wings. They say, hey, I got enough. I understand. I can manage it on my own. That's that resolution stage. And we want to see them get there. So Papello says, hey, these are the four overlapping phases. So Rosenstock, health belief theory. It is, look at what the word belief, what belief means. Tries to explain why a person will or won't take action to prevent or detect an illness. Why won't that person go have that colonoscopy done? Why won't that person go have that mammogram done? The person says they're feeling sick. They've been, having a fever for 5 days. They've done home remedies. It hasn't gotten any better. They still are febrile. Why won't that person just go to the hospital? Let them run some tests. So Rosenstock tries to explain why a person will, some people at the drop of, I don't feel good, they're in there. Hey, I don't feel good. Let's run every test and see what's going on. But then some, they won't take action. So perceptions vary and may have no basis in reality. It may be just because they just don't want to. They can't give you any other reasons. They just don't want to. Beliefs are connected to existing barriers. It might be that, access, how do I get to the hospital? If I go to the house, if I go to the doctor's office, they may say I need to be seen by a specialist. How am I going to get to specialists? We live in a small town. We don't have any specialists here. If they refer me, how am I going to get there? A cue to action is seen as necessary. So what do they believe about their health care, the health that they, their health status right now? And then we have Roy's adaptation model, describes the recipient of care, the client as a holistic adaptive system. So we're looking at the client as a whole. We're not just piecing out the hypertension. We're looking at that this person might have a limited income. This person might have maybe underinsured. They may have insurance, but it's not enough to cover, the services that they need. This person might be living in a high polluted area. So we're looking at the whole person. Both internal and outside stimuli does affect the system, affect our bodies. So Roy says we need to identify the types of stimuli as focal, contextual, residual, regulator subsystem, or cognator subsystem. So focal, referring to something direct, such as a client experiencing pain. The person's head hurts, foot hurts, they're experiencing pain. Contextual, meaning other factors that may affect the focal stimuli, like being examined in the area of pain. They say their left foot hurts. So we are looking at the left foot. We're putting it through range of motion. We're doing the tactile, we're touching it, so forth and so forth. Residual, referring to both internal and external factors that may not always be evident. Okay. So these are things that we will probably get out that may come out while we're doing our head-to-toe assessment, while we're asking questions. If they respond yes, positive to something, we ask those more focused questions. So this is where that other information might come out about internal and outside factors. Going back to the pain in the foot, it could be the person got some new shoes, where they, in the conversation, have your foot, when did it start hurting? Well, it just started today. Well, what did you do different today? You ask those more focused questions. Okay, coping mechanisms, regulator and cognator. So regulated subsystems refers to the internal effects that take place in response to what is happening internally. Okay, cognitive subsystem refers to learning, processing, judging, and emotion that the client uses to cope with what has happened. That's ROAS. Okay, we talked about the Joint Commission. It is an independent, not-for-profit organization that develops and applies standards for quality and safety in healthcare organizations. Usually you see JCAHO, Joint Commission, in the hospital. You see signs about them. You all may have been doing clinicals, and Joint Commission came in. Usually when it comes in our facilities and we're doing clinicals, they tell us, hey, we got to go, we have to go home. This is just that big to do. They come in and they're not for profit, but they look at everything from head with a fine-tooth comb, so to speak. They look in the records, they watch the processes, they may observe the nurse giving medications, may observe the nurse doing wound care. They look at everything. It's an on-site survey that actually evaluates actual care processes. They look in the charts and everything. They look at the policies and procedures, but they actually watch actual processes. Where some hospitals, they might do that sterile process. They may go down and look and see, what happens, during each step. The Joint Commission is also recognized creditor for CMS Medicare certification. What does that mean? If a facility is receiving Medicare funds to pay for that patient services while they're there, then they have to let Joint Commission in. They can't say you can't come in. You have to allow them to come in and look at the processes, look at the documentation, because that's part of how they keep their accreditation, and then also how they get their reimbursement. Okay, so we're looking at James Watson's theory of human care. Okay, so someone read this for us. Read this slide for us. Go through the bullet points. Watson.
Health is harmony among the body, mind, and spirit. Do you want me to do the whole thing? Okay. Involves self-perception and how the self is experienced. Illness is lack of harmony within the self and the soul. Nursing role is a caring process to help the client regain harmony and health.
So again, just like we were looking at when I asked you to create this healthcare system, this perfect healthcare system to meet everybody's needs, to meet the facilities needs, the healthcare provider needs, the patient needs. These theorists, they're just coming up with all of these different ways of looking at care, the whole person. And that's all these theorists they're doing. They're just looking at it in different ways, different avenues. Okay, so nursing research identifies specific nursing interventions that are proven effective and not merely based on tradition. Provide evidence that supports the quality and cost effectiveness of what nurses do. They generate knowledge for clinical practices. This is why we're doing what we're doing. So we did talk about quantitative and qualitative. I've talked about this in the exam review. I know we haven't talked about it before here, but in the exam review, we talked about quantitative. So look at the root word, quantity. So this is going to be things that have measures to them, measurements, height, weights. This is research that we gather through measurements of some data, whether or not it's the patient's echocardiogram. Remember, it measures the heart function, in percentages. Whether or not it is the EKG, it's that measurement of that heart rhythm. What about when we draw blood? For example, if we're doing a CBC, it's that measurement of how many blood cells are there or not. So it is, if we're measuring heights and weights, it's that quantity. But then we have qualitative. Qualitative is we gather information through lived experiences from people, from an individual. And it could be where we're sitting down having one-on-one, face-to-face conversation with, and that could be via Zoom or in person. Usually have a set of questions. They're not just pulling questions out of the air. They have a set of questions based centered around whatever their topic is. It could be, opportunity. We just throw out an example. Opportunities to exercise in your neighborhood. Do you have sidewalks? Do you have proper lighting? Do you have an area that you feel that's safe, that you can walk, run, jump, hop, and so forth? But qualitative, you gather information, but it's through that person's lived experience, and you more than likely are having an interview. And this can come in the form of a survey. They can send out surveys for people to, electronic or in on paper, but they're answering questions. Versus quantitative, we're actually measuring a person's height. We're drawing blood and we're measuring the amount of blood cells. So qualitative versus quantitative. Okay, so we have evidence-based practice. Dr. Cochrane, a British epidemiologist, challenged the public to pay only for medical care that was proven to be effective. So he advocated for the use of randomized controlled trials as means of reliably informing healthcare practices. So randomized, so that we're not just specifically picking certain people or certain things, but we're just randomizing it. The Cochrane collaboration was established to prepare and promote the accessibility of the Cochrane Reviews, which is a collection of evidence-based healthcare interventions that they got from the systematic review. Okay. So we talked about the Institutes of Medicine. They, provide these, help assist with providing these standards for the care that we actually provide. Okay. So during the last 2 decades, insurance companies began to pay for healthcare practices only if their effectiveness is supported by scientific evidence. How about that? So in the event that someone's doing a research study and they say, hey, it shows promising for whatever, lowering someone's blood pressure, lowering someone's chance of developing, a disease process. If that information is still in the trial phase where they're still gathering data, insurance companies are not paying. They call it, what's that word you all, they call it when it's not evidence-based? Experimental. So they don't pay for experimental. If it hasn't been supported by scientific evidence, it is not in the last 5 years and saying, hey, this is what we need to give, to alleviate a fever. This is what we need to do to get this person back up and walking. Based on the evidence, then the insurance company, you can go on and move on with those services and those different interventions, but they're not going to pay for it. So, but yeah, they look at the latest information, the latest evidence information. So the clinical question being invested, this is sort of like the PDSA, that PICO, and also the PICO question. It's sort of kind of like our care plans too, how we formulate an objective, and we create we select the guidelines, the goals, what we're going to actually implement. So it is, all of these things are kind of really based on the nursing process. So elements of evidence-based practice, it is what it says. We have evidence that guides what we are actually doing. That's what evidence-based practice is. We're not just pulling things out of the air. We're only going to give a half of a Tylenol. Well, based on the evidence, it says we should be given a minimum of 325, 2 tablets, or whatever the dose is. Okay. And this is just showing different roles, practical nurse, we know all of that. So the practical vocational nurse's role in evidence-based practice. What do? You can have a career in research. What do? More than likely those measuring the heights, the weights, drawing the blood, doing the EKGs. This is what we will assist with in gathering that information. But there's a protocol. I've seen where protocol, for example, something is, we check blood pressure so often, but when we're doing research, sometimes they want you to use a certain arm. They want you to actually measure the person's arm before putting on the cuff. And so the measuring the arm prior to is to ensure that the cuff actually fits the person. But what do we usually do when we go measure someone's blood pressure? We put that cuff on. We use our fingers to gauge and make sure it's not too tight, right? Make sure that we have the cuff on appropriately. But with research, it's so specific as to you measure that person's arm with the tape measure. and then you identify the correct cuff size. So, but nevertheless, it's part of gathering that evidence that will guide what we're supposed to be doing. So the spirit of inquiry, you usually see it in new nurses. You all are the ones that usually raise those questions because you have the latest information. While we are life learners, still you all have done research papers. You all are getting together with your group projects. So you all are looking at the latest information firsthand, lately. So when you go to your facilities and you see processes, you all are the ones that usually raise those questions. This is not being disrespectful. The whole idea is, can we provide the best care for a client? Use less resources, less time, and still provide and have the best outcome for our patients. That spirit of inquiry is a good thing. It's a good thing. So, but what comes with that, you might be asked to be on that team to help revise that policy. And I know you all have seen policies and procedures, and they are usually long and that word counts out this world. But anywho, nevertheless, in the event that you identify something that you think we can do a little bit better using less resources, and that patient will have better outcomes, why not? Let's try it out. Let's use that PDSA cycle. Okay, thank you for letting me know that. See. Yes, again, if you're having issues, connectivity issues, any issues, please put it in chat so we can have it all documented, to account for our time. All right, so let's look here. So what do the Joint Commission, what do they do? It's the Joint Commission.
Don't they provide safety standards and protocols for organizations?
They do. They actually come in and they look at that. They look at those. They have those protocols. They come in and they look at the process. They actually look at the nurse, observe the nurse administering that medication. They listen to them go through the 5 rights. I mean, not the 5 rights. That's delegation. The medication administration rights. They look at the doctor's documentation. Person comes in with chest pain. They look at the documentation, the orders, because it's expected. There's already established algorithms. Person complains of this. These things should be done. So they look at the physician's orders, the care plan, and they look at the documentation. Do they all match? And so, so usually you see them in the hospital settings, because the long-term care facilities have a different governing body or regulatory body that comes in, and they do the same thing. They pop up unannounced and they come in, they look at everything. They just want to ensure that we're providing the best care for the patients that we're administering care to. So remember, we talked about unit-based training, and that is where you'll get that unit training. But nevertheless, in order to maintain your license, you want to identify either some specific goals you have for yourself in reference to, what other information you want to add to your knowledge base, whether or not you want to strengthen what you already know, so you can find webinars or attend, different events that they may have around that subject. But nevertheless, you're going to create this personalized development plan with your specific goals. And it's just an ongoing thing, because at the end of, in some states, LPNs renew an odd year. Some states is vice versa. So whatever that time frame is, whichever state that you're in, you have to have these number of hours. They call them continuing education credits. They call them different things, but nevertheless, it's knowledge that you have to be certified or checked off on that you gain in order to maintain that licensure. Most states, at a minimum, that's one thing that they do require that you do. And so the facilities will require that you go through training, and you may have that unit-based training as well. I did mention to you all, schools of nursing were trying to start these residency programs, just like you see the residents, the MDs working like in the hospital settings. Um, they're still in school, but then they're, practicing, with some restrictions, as that healthcare provider. You see that transitioning, um, also with nurses too. They're starting to open it, and also they get pay. They call it stipend or something, but nevertheless they do get that incentive. So you do see that opening up. We do know when COVID came about, they opened up new professions were formed. And I think it's did you all remember different professions? What was the name of that it wasn't they weren't called a nurse, but they were doing almost what a nurse would be doing. You saw it at long-term care facilities. What was that? What you all remember that? You all did hear about that? If you had made it through a certain course in your nursing program, facilities would hire you. You didn't have to take a board. But since then they created a new profession. It's really they were administering medications is what it was. Is it medication administration assistant or something to
Med-Aid?
med aid, something similar. They may have different titles. The titles may vary, but it's something similar to that. When COVID came about, I think if you hadn't made it through like your second semester, do anyone know anyone that was actually able to do that? They were still in nursing school, but they had made it so far and they were able to, facilities hired them. They had some oversight and some restrictions. I think like they couldn't give PRN medications and they couldn't do something with a feeding tube. But for the most part, they were pretty much independent. But yes, so from that, new professions were actually created. But medication aid, something like that title was created. And so let's see here. I got some more slides I wanted to just review. Any questions so far about, let me pause and look at the chat. Are there any questions about any of the concepts that we went over so far? Any question? Okay. And so we were talking about the evidence-based practice. And so hopefully facilities, policies, procedures have been revised and they're compliant with whatever the latest is. But usually if there's a complaint from the facilities, they just say they don't have enough time. They're just trying to take care of the people that are there. They don't have enough time to actually research, go through all the literature. Because just think about what the project that you all are presenting for Group 10. That's kind of time consuming it is time consuming when you're looking through the literature because there's so much out there and you're trying to narrow it down to the best processes, the best information. And so, but nevertheless, that having that lack of time it doesn't alleviate a facility from getting cited if JCO comes in and they're not implementing the latest evidence-based practice. That's not an excuse, but usually that's what they usually say. Well, hey, we just haven't had enough time. But most facilities, what they've done is they've created these teams, these committees or teams, some facilities call them. And then they, in addition to your normal tasks, you'll be on the ethics committee, you'll be on the research committee, or the policy and procedure committee. But as part of that, they want you to do research to make sure that they are implementing the latest information in their facilities here. Okay, just going back through these slides, just making sure that we've talked about them enough here to make sure. Oh, I want to go back through these right here. Yeah, let's go back through these. Checking the chat, I don't see any questions in the chat. Okay, let me share my screen. So what did Cochrane say? The theorist Cochrane. What was it? What was his focus on? What notes did you take about Cochrane? What did you take away? Anybody, you come off mute and tell. What was your takeaway from Cochrane? Nobody? You all didn't take notes on Cochrane? I don't believe that. What we say about Cochrane? He's one that you really haven't, you kind of don't hear, but believe it or not, this is really what we're doing. Remember we just said the randomized control trials. He advocated for that. And so his thing was that those would be the ones that would be most reliable rather than us specifically hand picking, you know, people to gather data from. Just a randomized control trial. And then, so the Cochrane collaboration was established to prepare and promote the accessibility of Cochrane Reviews, which is a collection of evidence-based healthcare interventions. These are things that we're implementing, obtained by a systematic reviews of research. So they had a specific system in place. Remember, I just gave you the example of where they were measuring blood pressure. Instead of just putting a cuff on, they actually measured the arm. They used the right arm unless it was contraindicated. They selected, after measuring the arm, then they selected the cuff based on that measurement. And they might have checked the blood pressure twice and gotten the average. They may have written down all three blood pressures. But nevertheless, it's a systematic way that they're collecting this information. And then they review that information that has been collected in a systematic way. That we're just not haphazardly, well, let me just check your blood pressure. Some people we check it on the left arm, some we check it on the right arm, some we measure the arm width, and some we don't. It's a systematic way of collecting the information. And then it's randomized. You know, we're not just specifically picking people to gather this data from. It's whoever pretty much volunteers and wants to be a part of it. So that's randomized controlled trials. The control part is where, for example, we were doing blood pressures, you know, we're measuring the arm prior to putting on the cup. If we were collecting blood, we're collecting the same blood test. You know, we're collecting CBCs on everybody. We're collecting, you know, lipid panels on everyone. So that's the control part. All right, so let me stop sharing in the chat. I want you to tell me what you remember about Cochrane. What's your two takeaways from Cochrane? Let me put the time on. I'll give you 2 minutes. So what are your takeaways from Cochrane? Find my little clock here and start. Put it into your own words. $59. Oh yeah, and send it out so everyone can see it. Okay. Time is up. Let me see what you got. Evidence-based, evidence-based treatment, systematic review. So the big two things is systematic, evidence-based. Good. Medical treatment should be based on scientific evidence and the proof. Got it. Okay. All right. So we kind of mentioned, or we have mentioned the FDA. What does the FDA regulate? Put it in the chat. What does the Food Drug Administration, what do they regulate? FDA.
Whatever food or drug is safe for consumers.
So I do see product safety. So what is an example of product safety? Because we got food and drugs in the title. So, but usually we forget about that products or equipment or supply. So think about a person that's had a stent put in. Think about a person, I mentioned all the time, a person getting the hip replacement, the knee replacement. Think about that device that they put, that artificial hip they put in. Who oversees it says, hey, this device is safe to put inside of someone? So the FDA, that's who they do, foods, drugs, and the equipment or products. Exactly. You are right. Good, good, good. Don't forget about that part. Okay. And so going back to evidence base. So just think about you all are gathering your information for your project here. Let's see. So evidence-based, it is what it is. Evidence. Evidence-based practices involves integration of three key elements: the best current evidence, clinical expertise, and the client preferences. Those things are all part of the evidence. So for example, in the event that they have 3 blood pressure medications that are out there for a person that has hypertension. The patient has tested all 3 of them. They all 3 are evidence-based that they do assist in lowering that blood pressure, getting that blood pressure back to be therapeutic. But the patient says, hey, the second medication, that one, I feel better when I take that one. The first one, it makes my feet swell up. The third medication, while still lowering the blood pressure, the person is having, the feet are swelling, or the third medication, the patient may say, hey, I feel funny when I take that medicine, but when I check my blood pressure, it's fine. While all of those do assist in lowering that person's blood pressure, but the client may prefer the second medication. So we do want to incorporate their preferences in, because after all, they're the ones that's actually getting the care. So the current evidence, these three medications have been found to, assist the person with lowering their blood pressure. And this is just an example that I'm giving, just trying to put a story with what we're saying here. And so we don't rely on outdated traditions. For example, if a facility says, hey, they have a medical provider that sees the patient in the facilities, long-term care facilities, and that doctor always orders that one medication, no matter what the blood pressure measurements are, no matter what the glucose numbers are, they always order that one medication. That's not evidence-based. That's not evidence-based. That does not support evidence-based practice. We want to use clinical guidelines, research findings, and including the client input. This ensures safe, current, and individualized care. We do want to take into consideration that client said, hey, I've taken all 3 of those medications and they all lower my blood pressure, but the one I feel the best taking is the second one. The first one makes me my foot swell. I may have swelling in my legs. And then the third one, it makes me feel funny. So we do want to take their input and then implement that, because like I said, after all, it is them that's receiving the care. All right, so we are down to our next break. And then of course, we save our last few minutes toward the end, last 15 toward the end. So again, let's go ahead and let's return at 7:35. Then we'll take it on out from here. Again, this recording still plays, so make sure your mute is on mute, microphone's on mute, and then your camera is off. Okay, let's go ahead and review everything this last time. Don't forget week 12. We do meet briefly, so that week looks a little bit different from the rest of it. We do not meet the entire time. If you have classes in the past, if you had a class on Wednesday, Thursday, and Friday, but it will be communicated if there is a change in schedule, because been happening over the last couple of years, campus is usually closed at noon on Wednesday. It might be different this time. So, if you receive a notification from someone, your instructor, your professor, and they say, hey, we need you to meet on Monday, Tuesday, a different day than your class normally meets, just know that it's not for the entirety of the class. And it is for attendance, because you still must meet that requirement. Of course, it's always up to you to come or not come, but I suggest coming because it does still count as if you miss attendance, but we're not there not that long at all. The surveys, they come to your Outlook mail. You should be getting them every quarter, every term. It comes from education affiliates. Be on the lookout for that. Complete this survey. If there's something that does not apply to class and you can't bypass answering that question, answer the question. And then there's usually a free text part, and just type, hey, some of these things did not apply, but make sure that you're looking out for that. For sure, that should be coming out week 11, but it comes to your Outlook mail, not inside your Canvas mail. So talked about week 12. We meet shortly. We usually go over the national data comparing to ours. And then week 11, your HESIs. Remember, they might not be at the same time that your classes are traditionally held. May not be on the same day. You may have your class that you normally take on Monday, that HESI might be on Friday. Remember that it is campus specific. So it depends on what your campus deans tell you about that exam. So make sure you're finding out information for you in your campus. No later than week 10, you should be receiving information, because week 11 is when that's when generally all HESIs are taken. And then week 10, we will hear from you all. We will hear from the
I was going
group
to ask a
project.
question.
Mm-hmm.
I was going to ask a question. Yeah, the group project. Do we all upload it individually? Like the finished product, we all upload it individually, and then we're going to read from it in the class?
Exactly. That's correct.
Okay.
Everyone turns in the final product. Whatever if I completed slide 1 and you completed slide 2, 3, and 4, and someone else completed slide 6, we turn in that final product, which is slides 1 through 6. All of us are going to turn in the exact same final product. And then you all present as a group, though. And you all decide what you're going to present and what you're going to say and all of that. So that is week 10. Week 10, we do that, and then we just go back over everything, because HESI is all encompassing. What you're going to see on HESI. That these are, for the most part, the concepts that we went over will be there. It might be definition based. What we've heard from students in the past is heavy on delegation, is heavy on communication. So week 10, we go back over the content, from the term, and then we listen to our presentations. We essentially today, no new content. This is it for content. Then next week we do the exam, and then of course we meet briefly after to start back reviewing the content, because you do have the NCLEX and you do have HESIs. So just the more that you hear the information, you can quickly recall, and then those concepts that you need to spend more time on, you can go ahead and identify those. And so you'll be ready. You'll be ready. Okay, so we're gonna do just a quick review over everything, and that should take us on out here. Again, be jotting down those things, those concepts that you still are like, what they talking about? Make sure that's at the top of your list to go, to spend more time with. All right, so we have official government healthcare agencies. They're supported by tax money. Primary service, we want to prevent diseases if we can. We want to promote health if we can. You've seen the summer's coming. I do remember last year they were promoting, water consumption. If it wasn't contraindicated, you say all these people were handing out water bottles. You saw these big billboards. People were drinking. They had, fountains up. staying hydrated, beat the heat, stay out of the heat. I forget the little jingle that they had, but health promotion, we can prevent someone from um, being injured by the heat or the cold, then that's less services that this person is going to need. This is less finances that they're going to have to spend on healthcare. This is less harm, this person, because sometimes people don't get back to their optimal level of health after they've had these injuries. And who would have thought the cold would do that to someone, or the heat? Yes, people can, have heat strokes, and before the heat stroke, they were taking care of themselves, and afterward, they were total care. So we can prevent a disease, and or if we can promote, prevention of a disease or injury, we want to do that. We do want to actually do that. So we do have official government agencies. We have the local, the state, and the federal agencies. And then, who pays for these things? It depends. Some things are funded by the state. Some things are funded federally. And then some things are funded locally. And so that's just how it is. It's how those services are paid for. Now, we talked about the check stub where you have all these deductions that come out. Of course, some of those deductions goes to those different pots of money or bags of money, and helps pays for those resources that are available for us. Okay, so we do have federal regulatory agencies. We have Medicare and Medicaid. We talked about the value-based purchasing, which links incentive payments to hospitals' quality. Remember the examples that we gave? We talked about people getting UTIs, urinary tract infections, having falls, wounds, and so forth and so forth. And they have a standard. The standard is these people do not get a urinary tract infection, that they do not get ulcers, or they do not fall just because they're in a hospital. And what they do is they incentivize. They provide extra funds in the event that a facility is meeting the standard and exceeding the standard. So OSHA, prevent work-related injuries and illnesses and death. And then in the event that you're in a facility, it doesn't matter it's not minimal. If we're supposed to be standing on a slip-proof rug and the slip-proof rug is torn, that needs to be reported, because there's a reason why that rug is there. They're saying that we need to have certain PPE on when we're taking care of this patient, or we need this in order to provide this procedure. We want to get it so that we can provide it, because we want to prevent work-related injuries, illnesses, and deaths. Believe it or not, people actually die from things related to, they were in the workplace. Things might not have been available. Equipment was not working properly. We want to report those things. So the CDC, research, data collection, controlling and preventing diseases. Usually they alert us. They sit there, and these nurses and healthcare professionals, they gather all this data. They're looking at numbers. We do know that there are certain reportable diseases, and they go into these databases, and the CDC, they look there and they say, hey, we have a high number of this in this area. So they send out the information, and states and communities begin to implement intervention so that we can mitigate, get rid of it, or at least lessen the chance of it injuring or causing illnesses to the people that live in the communities. We talked about the FDA, assuring the safety and the efficacy and security of human and veterinary drugs, so medication, biological products, medical devices. We talked about food, stents, the hips and the knees. Who oversees these things and makes sure that these things are safe to put inside of people? The U.S. FDA, Food and Drug Administration. So these regulatory agencies, they're there to protect the public and also us as healthcare professionals. They're there to protect us. Organizational services must meet minimum established standards, safety standards, focuses on quality improvement. Accreditation is not always mandatory. The JCAHO, the Joint Commission, uses quality and safety measures to certify. They use this to certify healthcare organizations, particularly hospitals. So they come in, they actually look at those processes, see what we're doing. We're saying we're supposed to be sterilizing equipment. They actually stand there and look. They look at the policy procedures. They see what we're doing. Do they match? What are the rates of our what are our infection rates? Is it related to the policy and procedure, or is it related to the person that's not following the policy and procedure? So we have these private healthcare agencies. Services must be paid for. Who pays for them? They also provide wellness and disease prevention. That it's still all about that healthcare. Home health is provided, for someone that is homebound. They must have that skill in order for that insurance to pay for it. So what are skilled services? So skilled services, for examples, are person just had a stroke. They need that therapy to regain, to know how to walk again, how to feed themselves, to eat. They may need speech therapy to work on, the eating process, breaking down that food. They may need IV medications. They may need wound changes. This is not an all-inclusive list, but the whole point is they must have that skilled care, medically necessary to improve health or to maintain or slow decompensation. So hospice and palliative care. You can receive palliative care at any stage. We know hospice care is generally, the goal is toward the when someone's been given that terminal diagnosis, when pretty much death is almost imminent. But I've seen people on hospice and they come off of hospice because their condition improved. But it's usually conserved, saved for, we're maintaining comfort and dignity. And hospice services can be received inpatient. A lot of hospitals have inpatient hospice units. Can be received in the home. A person can be in a long-term care facility and be on hospice, and the hospice staff will come in and take care of them in that facility. But palliative care, comfort at any stage. The person can seek palliative care at any stage in their disease process. And then life-saving measures can be chosen with palliative care. Usually life-saving measures in the event that the person's, life-saving, like without heart rate, without blood pressure, pulse, and things like that, respirations, life-saving measures usually are not rendered unless the person changes their mind and say, hey, I want to drop these services and I want everything done. Okay. So these are different settings that we can provide healthcare in. This is not an all-inclusive list. We talked about Medicare, 65 and older, federally funded. And, how do that money get put there? A person should have at least worked 10 years. And, it's put there. So it's not free. It comes from somewhere. Okay. We said Medicare has the 4 parts. Inpatient, meaning hospital. We got inpatient, meaning skilled nursing facility. Outpatient, doctor's office visit, even if they have an outpatient surgery. And then we said D, like Danny, was prescription drugs. And we talked about this C right here. C is offered by a private company that contracts with Medicare. Like A, B, and D are like automatic, but C is optional. But with C, it can cover the services that are not covered by A, B, and D, and it also can provide that extra drug coverage. We talked about Medigap. It stays in the gap. Those things that are not covered again. It depends on what the disease process is and what labs you need to continue to have done, with x-rays or, exams you need done, even the number of visits that you have to go. Sometimes there are a lot of visits people have to go for if they have a disease process. So, what helps pays or offsets these prices so these patients don't have to pay out of pocket for these services? Medigap. So we said Medicaid was income-based, usually low income. It is income-based, usually under 65. CHIP is that limited income where the family makes too much to qualify for Medicaid, but then there's really not enough funds to pay for that private health insurance. So it covers the children up to 19. And yes, they still get the preventative care and the regular checkups. That's the expectation. Uninsured, if a person does not have insurance, hey, I'm not running to that doctor's office too often because before I go back there to see the doctor, they're going to want, if I don't have any, they'll either want that insurance card, that copay, or they're going to want that cash money, via Zelle or however you get it to them. which is a huge price. So usually people wait until late in the disease process to seek out treatment. And usually it is done in the hospital settings because remember that act, the EMLA, where they don't turn you away. The Affordable Care Act, we talked about it. It expanded Medicaid eligibility if states wanted it. It removed those pre-existing penalties. And also employers were asked to provide health insurance to the employees, because usually it's at a cheaper rate. We talked about MCOs, healthcare providers and insurance companies share that financial responsibility for improving the quality of healthcare. Patients pay that monthly premium, they subscribe, and then are able to choose from different plans. So within the MCO, you can choose the PPO plan or the HMO plan. Okay. The PPO plan may allow patients to choose providers out of network. And then price of healthcare goods and services are set beforehand by the insurance company. And so what that means is the price come up and it's outside of that price, who's going to absorb it? Patient or their healthcare facility. ACOs, this is where they define processes for promoting evidence-based medicine, and they want you to report it. They want you to report what's going on. How many readmissions have we had? And so they look at that, and they saying that makes facilities more accountable for making sure that they take care of the patients, provide that best care before discharging them. Make them accountable because they know that they're gonna have to come back and report. Hey, was this person readmitted within 30 days, or this person was not readmitted? We talked about QSIN. The overall goal is to prepare nursing students with the knowledge and skills and attitudes necessary to continuously improve the quality and safety of the healthcare that they're providing. Okay, shared governance, shared decision making based on the principles of partnerships. Think about shared partnerships, equity, accountability, and ownership at the point of service. The power to make practice decisions characterizes the autonomy of nurses to control nursing practices. Think about that shared governance. We're sharing this. Successful implementation of shared governance model in nursing requires a foundation of collaboration between the units and departments, between home health and the hospital. The person's getting ready to be discharged from the hospital, they're going home. So it's that shared governance, that collaboration between the two entities. Persons going from ER to med-surg to ICU. So from unit to unit, department to department. So there are clearly defined roles and responsibilities, help staff understand their authority and contributions within that model. Open and transparent communication. Continuous education and leadership development for nurses support effective participation in the governance activities. Remember, we talked about that unit-based training and so forth. Future of nursing. These are just some things that they've kind of foresaw, but we're past this 2020 now. We talked about STEAM, safe, timely, effective, efficient, equitable, patient-centered. Okay, how best evidence for practice guidelines is determined. The clinical question being investigated is formulated in an objective, concise manner. We're looking at adults between the ages of, you can do gender, you can do race, that have hypertension or that has, systolic blood pressures over 140, whatever it is, you're being concise about it. Using professional resources with the latest relevant research. If we're talking about blood pressures, our research should not be about bananas. The information that we're going to present, it should be about whatever that topic is. An expert or panel of experts conducts a systematic review. So guidelines are determined using critical thinking skills to gather evidence is combined with clinical experience and the client's preferences. So it's like 3 things in there. Well, critical thinking skills, clinical experience, and client's preferences, and values for use in specific clinical situation. So we got the best research, we got the nursing clinical expertise, and the client's preferences. This is just different types of evidence. You know, whether or not it's animal research, whether or not it's a case report, they're all different types. We talked about quantity, a measurement. Okay. We talked about those randomized control trials with those systematic reviews. Qualitative is a lived experience where you're gathering information through an interview, whether it's in writing, face to face, verbal. Okay. Finding solutions to questions, develop an answerable question. A strategy that can be helpful in designing an answerable question is using we say the PICO or the PICOT formula, which stands for population, intervention, comparison, and outcome. PICO or PICOT, because the T is time, but for sure you need to know population, intervention, comparison, and outcome. We searched the literature. What evidence did we find? Is this evidence matches what we're trying to ask about, or is this evidence irrelevant? You know, we're asking about blood pressures in people that are 5'6", but the research that we found, some of it is about blood pressures in people that are 6 foot. So that's not relevant. So we evaluate the evidence to see if it's specific to what we're actually looking at. And then we apply the evidence to practice the situation. And of course, you know, we always evaluate. Need to know. Okay, here it is, looking at it again. So what is the population or the patient? Define who or what the question is about. What are we going to do? What is an alternative? What is the second thing that we could do? And then outcomes, define the important outcomes, beneficial or harmful. And then over what time period? Remember I told you the T meant time. Over what time? Are we doing this for 6 months? Are we doing this for 6 weeks? What is the time frame? We went over PDSA. We did say you can get down to the do part and go back to the plan part. It doesn't mean that you have to continuously go around, that you can't, you know, go backwards and forwards. All right, health policy relates to a health concern or issue and or meant to address public policy goals, okay? We talked about the PDSA, the MLA, you know, can't turn people away, the OBRA, you know, it reformed long-term care by requiring those comprehensive resident assessments. Many of you all, we talked about the MDSs. It specifically says patient in room 201, they need one person to turn. They need, they just need set up to bathe themselves. They need set up help to feed themselves, or they need one person to assist them. So OBRA significantly reformed long-term care, requiring those comprehensive, detailed assessments, telling us about how much care a person needed. Okay, Anderson, it pretty much still kind of follows that care plan. You know, we decide, we gather this information. What are we going to do? We implement it, and then we come back and evaluate it. So we went over this right here, the quality assessment models, you know, the structure where we're actually looking at where in that school of nursing, in that building, that's where care is provided 2 or 3 days a week by the staff. You know, the outcome, we're looking to see whether or not people with A1Cs less than 9, are they having to go to the hospital, or are they really managing the care? All right, so we're just going back over everything. Is there any one question about any of these concepts that we have went over? Anything? The National Quality Forum, a not-for-profit membership-based organization focused on meaningful quality measurements. Everything you all is the same. They want to make sure that we're providing that best care. Professional development is continual, life learners. Okay. I think that was the last slide. All right. We look and see if we have any questions in the chat. All right. So the exam reviews, as the links are provided, they're going to be placed in the announcement section. There are still, I think, 3 more because there are 5 of us. So just look at the schedule, see if you can attend. If not, at a minimum, commit to going through our classroom recordings, exam reviews. Take care, and we'll see you next week. Don't forget about if you want that exam proctor, what that policy says, send an email with your approved proctor to your campus dean, the approved proctor, Dean Brown, and myself with the plans. Take care, and we'll see you next week.
Have a great night.
Thank you. You too.